Hello everyone, welcome to our webinar entitled Immune Health and Nutritional Testing. Our guest speaker today is Dr. Susan Blum. My name is Christine Stubbe and I am a medical education specialist at Genova's Asheville branch. I am going to serve as the moderator for today's webinar. We would like to welcome Dr. Susan Blum. Dr. Blum is a true pioneer in functional medicine, a nationally recognized clinician, speaker, author, and teacher. As the founder and director of Blum Center for Health and through her education, writing, research, and medical mentorship program, she is revolutionizing the healthcare industry and the lives of those with chronic illness. Dr. Blum is a member of the Medical Advisory Board for the Dr. Oz Show and the Institute for Integrative Nutrition, and she is on the board of directors for the True Health Initiative in the College of Lifestyle Medicine. Dr. Blum completed her internal medicine training at St. Luke's Roosevelt Hospital and is board certified in preventive medicine, certified in functional medicine, is senior faculty with the Center for Mind-Body Medicine, and author of the Immune System Recovery Program. And we should be good to go here, Dr. Blum.
Okay, well, hi everyone, and I'm really happy to be here today to share with you some of the ways that I evaluate and then use what I learned to work with my patients with immune issues. While I am certainly very experienced in treating autoimmune disease, not only because even before I wrote the book, that seems to be what a lot of people come into a functional medicine office for. It's a very common health issue, as well as people who are, struggling with their immune system, sick all the time. But autoimmunity has become a really prevalent issue. And also, since I wrote the book, it seems to be what everybody comes in here for. I have a lot more of those patients now as well. So I have found that over the years, I have discovered the best tools that I've used to evaluate what's going on and to try to get to the root cause of the problem. And so one of my favorite tests is called a NutrEval, and I guess that's one of the reasons that Genova came to me and said, do you want to talk about the NutrEval for us and how you use it with your autoimmune patients, because that seems you do a lot of that test. So I said absolutely, so that's why I'm here. I always like to start out, actually Christine already told you all this stuff. If anybody's interested, in any of these things that I'm doing, contact me separately. There's some really cool things going on in my conventional world of preventive medicine. There's the American College of Preventive Medicine, and now there's something called the American College of Lifestyle Medicine, which is really where I think the home of in the conventional arena, where functional medicine is going to land as a way in through the American College of Lifestyle Medicine. And so I'm on the Council of Directors for Glimmer. It's this True Health Coalition within that organization, and it's really all about nutrition and trying to teach people the right way to eat. But also there's a whole functional medicine wing in there. So I'm very excited to be involved in that. And of course, at the end of the day, I'm rooted in functional medicine, did my training at IFM and AFMCP about 15 years ago now, and really have learned a lot, along the way. And last but not least, we're not going to talk about today, but I'm really a very grounded mind-body medicine practitioner and have spent a lot of time teaching and with the Center for Mind-Body Medicine, and that's one of my passions as well. So that's a little bit about me. And 3 years ago, my book came out, The Immune System Recovery Plan, and it's really a functional medicine sort of guidebook on how to repair the immune system. And I learned so much. Besides learning so much from my patients all the years before I wrote the book, writing the book, I learned so much. And one of the things that became very clear to me as I was digging in through the literature and sort of really reviewing everything is the importance of nutrients, not only to help your immune system function at its best, but also as a foundation for helping the detoxification processes, which are important when it comes to your immune system and decreasing toxic load. And so looking for tools that I could use to really assess my patients nutrient status, and do they have deficiencies? Are they detoxing properly? How do I help them move through these repair steps? How do I help them heal their gut? How do I help them decrease their toxin load, because those are so key. And I kept coming back to nutrients as really foundation. So for me, step one is not only fix the diet using food as medicine, but assess nutrients, replenish what they need, make sure that their nutrient status is really robust between food and between what supplementation you might have to do to get them, where they need to go. And just a little point about that, I really am a food as medicine person. My goal is always to do short term. If I have to do a lot of supplements, I try to make it as temporary as possible, and always moving people towards being able to get what they need from food. And in order to get what you need from food, you need to not only clean up someone's diet, but you also have to make sure their gut's healthy, because there's a lot of malabsorption syndromes out there. And we'll talk a little bit about that as we go through my case studies and stuff. But getting people towards being able to get everything from food is a really great idea, and it's really a goal I'm always with all my patients. But in the short run, you need to figure out what the imbalances are, what the deficiencies are, and really aggressively work to fix those so that you can get there, right? There's a short-term need, and then there's the long-term goal. And I find that using the NutrEval test is what I use to as my guidepost to assess and then reassess, every, anywhere from around 3 to 4 months. I keep reassessing to make sure that we're getting where we need to go, and then to see if I can start cutting back on some of the supplementation that I'm giving people. So that's me and the book. So even though I'm an autoimmune expert, I think it's all about the immune system, all of these things. It's about, so certainly autoimmunity, and so I'm going to share a couple of cases of patients with autoimmune disease, but it's also those people that come into your office and say, I'm getting sick all the time. I don't understand, why am I getting sick all the time? And those are also people who might be reporting they're getting sick all the time. It could just be people with, fatigue, and when you look at sort of their testing, which I'll show you in a bit, maybe they have high viral loads, people that are walking around with very, a lot of infections, a lot of, Epstein-Barr virus and chlamydia and mycoplasma and herpes viruses, and they're just not clearing those viruses. And so that's a problem with the immune system. Your people who have these persistent viruses, why can't the immune system get rid of them? And so that's what I just lump into the category of low immune function. And so we want to figure out, why is the immune system not working at its best? And so these tools apply to that as well. Allergy and asthma are another dysfunction of the immune system, and so there's what's thought to be overfunctioning and underfunctioning, and I just categorize them all as dysfunction. It's just not working right, and that's true when it comes to autoimmunity as well. There's an overactive arm of your immune cells, and I think of the immune system as an army of cells, or just even an army of soldiers as an analogy, and there's just different divisions, and they all have different purposes, and sometimes there's an overactive arm division on one side and an underactive on the other. It's just dysfunction. And in allergy and asthma, clearly you have a real hyperfunction and in some parts of the immune system, and so again, the goal is, how do we find what's triggering this? How do we find how to help the immune system come back into balance? We're not really going to talk much about food sensitivities today, even though it is an over sort of active immune system in some ways, right? The immune system is reacting to foods that it really naturally shouldn't, perhaps, but food sensitivities are still an immune reaction, and so I included in some parts of our discussion today. Now, before we jump into how to use an integrative assessment, I think it's really important. I wanted to share with you, my thoughts about, what do you do in the conventional arena? So what can I get out of, and of course you want to, for me, I'm very into making sure people can get as much free through their health insurance as possible, right? So what can they get through insurance testing? What can they get through routine blood work? What kind of a conventional assessment can you do to evaluate sort of nutritional status, right, and or immune system? Mostly immune system is what we're talking about. In general, and this is a very sort of classic functional medicine sort of statement, is that, in functional medicine, we're trying to get to the root of what's triggering the immune problem. Most of the conventional testing that you might order and you might do is really going to be about getting to, looking at how well it's functioning. Like, do you have a problem in function? Do you have a viral load? Do you have a low white count? Those sort of things. Do you have antibodies? It's not going to really tell you, what's the cause. It's only going to help you diagnose or try to identify, where the imbalance or the dysfunction is. That being said, I still do a lot of, I have my standard tests. When somebody comes in, I have sort of my basic tests that I do, and it's really, I think, in some ways, it's not all that much, but it's very specific for me. I do a lot of autoimmune marker testing, so I look for a lot of antibodies. So I screen ANA on everybody, and for those of you who might not know, an anti-nuclear antibody is a very general marker. It doesn't mean you have a disease, but it's the first thing. So let me just back up for a second. In autoimmune diseases, there's sort of two different, I think for simplicity, we can just divide them in two different categories. The first is the sort of ANA systemic diseases like lupus, scleroderma, polymyositis, Sjogren's syndrome. Those are all the disease, those are like in the category of a positive ANA, and then you can get a cascade under the ANA to see if there's any specific markers for those specific diseases. And so those are the ANA diseases, and I always do the ANA screening, and I do a cascade to see whether or not any of those things come up. And then, depending on what's somebody's situation is, what they're presenting with, like someone with arthritis, I always check the rheumatoid arthritis markers, which are different. For example, or somebody with a hypothyroid history, I check all the antibodies for, actually I check all my new patients for Hashimoto's because it's so common, so that's an automatic screening I do. So, but that's where conventional testing is really good. I can go on a big search mission for antibodies, and I'm not going to go here into all the different ones there are, but given the clinical presentation, I might go looking for, antibodies to different things. And so that's a conventional test that's really helpful. I think that's the best place to go. There are some labs that do sort of less, there are some labs that you can get antibody testing through, but I find that the majority of it I can get through the conventional tests. In terms of looking at immune function, I think a white count is really important because when it comes to autoimmunity, it can be, and this is true for low immune function as well, someone with a chronic low white count, it can be a tip-off that they have a chronic viral load, and that's an issue in understanding what you need to work on with them. And so I think a chronic low white count is an important thing to know if they have. And the natural killers, sometimes I do that for autoimmune testing. Very rarely. I tend to use that more for Lyme disease and other marker for low immune function. But I put it on here because on occasion I'll use it. Then you come into all the inflammatory markers. I think those are key. CRP, sed rate, celiac markers. I screen everyone for celiac disease. Deamidated gliadin antibodies are sort of the first sign of maybe non-celiac gluten sensitivity, or even some studies have suggested that deamidated gliadin antibody positivity is just sort of early celiac that's not manifested completely yet. Vitamin D also is a conventional test. So there you have it. That's my sort of small little grouping of autoimmune testing that I do. When it comes to low immune function, I always do viral activity assays. And actually going back to autoimmune testing, if someone has a positive ANA and they don't have any, this is sort of a pattern, positive ANA, all the other markers are negative, so they don't have lupus, they don't have any of the other markers in the cascade, and they have a low white count, I think it's really important to do a whole look at viral load. because there's plenty of studies that link chronic active Epstein-Barr virus, for example, and a positive ANA. So I have a lot of people who show up with a positive ANA, and they have no other autoimmune markers. They don't have any clinical sign of disease, but they have a big, viral load, and to me, that's the reason that they have the ANA. And so for me, the goal then is to help their immune system, to support their immune system, repair it, get it working well so that we can put those viruses in remission. And so people with chronic viral, I think of them as the low immune function people. So vitamin D, again, you're always checking that. Let's see if there's anything else here different than the autoimmune people. People with chronic low immune function, I do this for autoimmunity too. I always do DHEAS, to just get a sense if I think their adrenals might be if there's some alteration of first, low DHEA is thought to be stage 1 of adrenal fatigue, or stage 1 of, some ongoing chronic stress where the DHEA drops down first. Through conventional testing, sometimes I'll do a 24-hour urine cortisol, and that's a more conventional test, which is nice, especially if you're going to be conversing with an endocrinologist who's conventional, and you really think your patient might have true adrenal insufficiency or very low adrenals. You can do a 24-hour urine cortisol, and that's something they sort of perk up and look at that level as something real, as opposed to saliva testing, which they don't always believe. The other thing that's really important for immune function is methylation status, and so homocysteine is sort of the bellwether nutritional marker in conventional testing that we use to look for B12 folate status. Sometimes it's not that helpful. Sometimes, I don't know, I've actually come to be a little bit leery about looking at homocysteine as just that, because I think sometimes people can have an upregulated CBS genetic SNP and it burns through their homocysteine, so, or low cysteine, especially if they've used up a lot of glutathione and they're low, so you can actually have people who have low homocysteine but still have B12 folate deficiency. So you have to look at homocysteine in a bigger picture too. And I know I might have just confused a lot of people. You can ask me questions about that later. That's just my experience over the years. I just, nothing is a perfect marker. Everything that you're going to measure is influenced by multiple things. And so you always have to take things with a grain of salt and look at patterns. And actually that is one of the things that I do want to sort of bring forth in this discussion today, is the importance of looking at patterns and looking at corroborating evidence and not just one marker, okay? Okay, so allergy and asthma. I definitely send people often to an allergist or ENT person to get the full, patch testing. Let's just see if you're having a true allergic reaction to anything, especially if they have active asthma, or really a lot of hives or anything really active that where they seem to be reacting to all sorts of foods and environmental sort of triggers. And so I think it's good to just know what you're dealing with. And especially, and so it's good to know what you're dealing with, especially if you do a stool test or you see in the CBC there's a lot of eosinophils. I think that's really an upregulated, like an EPX in the stool test or eosinophils in the blood. I worry about there being a true food allergy that we're missing, and so those are really the people that I'll often send off and say, I'll do IgE blood testing, but sometimes I do think it's good for them to get the skin testing because it is looking at different immune activated pathway. Okay, I'm not going to talk about food sensitivity testing here. This is not what we're here to talk about today, but I do try to test gluten as much as I can. Through conventional testing, I do the HLA testing as well. So I always screen everybody that way. And I really, in the conventional arena, there's no way to test for food sensitivities. That's really what this slide is saying. But what I would say is that because food sensitivities, and you all know this if you're functional medicine people, food sensitivities originate in the gut. It originates from, a leaky gut that then allows the body to see these, undigested particles of food, which then end up triggering, an immune reaction. Okay, and so if you take that a step further and say, well, if somebody has a leaky gut, then they might have, why do they have a leaky gut? Do they have dysbiosis? Do they have a real gut issue? Then one of my favorite markers for malabsorption, like what's going on in the gut? Are they able to digest and absorb their food? When you see someone with a chronic low ferritin and their iron is just really low, and I'm not talking about a young woman who has very heavy periods and is a vegan. You can understand why her iron might be low. But somebody, especially a postmenopausal woman, or man who is, or any man, but a woman who's postmenopausal or a man who is who has a really low ferritin, you have to really think about the gut. So in terms of conventional assessment, I think ferritin's a good marker for in someone with an adequate diet, that there might be something going on in the gut, which could segue into being concerned they might, if they do have something in the gut, they could end up with food sensitivities. It's a little bit of a reach, but I just figured I'd put that in there for you as the way I look at ferritin. But for food sensitivities, really integrative assessment is best. Okay. And that sort of brings me to the NutrEval, and I do want to, when I saw this slide for the first time and I saw the word genomics under it, I guess I'll give them a little pitch for the newest version of the NutrEval, that now you can throw on some genetic testing, the three of which I think are the most helpful is sort of MTHFR, COMT, and the ApoE test, which you can add on to this test now for $30 each of those markers. And as a price point, that is just a great price. And, I like to do ApoE testing with my patients to get a sense of, looking for those ApoE4 people who might, not be able to manage a high-fat diet as well in terms of just their ability to process it. Classically the ApoE4, the Alzheimer risk, and the high cardiovascular disease risk people, those are the people that might not respond to fish oil like your ApoE3 people. So it's really helpful to know their ApoE status. And of course the COMT and the MTHFR are going to help you understand why you're struggling to manage their folate and B12 deficiency that you're finding in the NutrEval. Just helps you know how to dose them and what might be going on in that, and also how that might be contributing to whatever health condition that they have. Okay, so my little pitch for the genomics, that's another whole webinar on how to use genetics in your practice. So we're going to focus on, we're going to circle back now and talk about the NutrEval and basically how I use it. And I'm going to give you examples of two different people that it was actually very important information for me that really drove my understanding of what was going on with them. Okay, take a sip of water. So, one of my favorite sayings is this thing called a high altitude view. When I get a NutrEval report, I thumb through it really quick and just sort of look at my overview and to see if sort of, what I was saying before about corroborating evidence, how one panel makes sense, how things make sense in groupings, and just a general gist of what I'm getting looking at an overall high altitude view of the test as I just thumb through. And I think that's really important, and in some ways I find that a lot more helpful than picking apart. Some people get intimidated by this test because there are so many markers. And what I'd like to share with you is that I actually probably don't dig into every high, every low and look them up and figure out what nutrient it is. I actually think that in some ways that's their job in the reports, and the computer program I'm sure that's used, to put together those individual things. I actually find it the most helpful and easy. Not that it's not that hard. At least I guess for me it's not anymore. And I have new doctors I brought on here and I train people, and everyone's using it now pretty effectively. You don't have to know every line item. I'm going to help you just use sort of panels to get a sense of what's going on with your patient. So my favorite panels to start with as I thumb through, especially when it comes to the immune system, are the dysbiosis markers, oxidative stress panel, and of course the heavy metals test, the red blood cell heavy metals, And then there's a little toxin detox markers panel, in there, which all, when I look at this first pass, sort of tells me a story. And let's talk more about that. Now, for those of you who don't know what dysbiosis markers are, this is the urine part of the test, and the organic acids. The NutrEval is a combination of urine organic acids and then blood work, which looks at serum amino acids and your essential fatty acid panel, and then there's oxidative stress markers in both blood and urine, and then there's the red blood cell, metals and minerals. So the dysbiosis panel comes from the urine organic acid. So anyone who's familiar with an OAT, organic acid testing, has some familiarity with this. And basically these are compounds of bacterial or fungal origin that end up in the urine, because you have too much overgrowth in the gut. Normally, the bacteria in your gut, and we all have a teeny bit of yeast. It's always little weeds in the garden, so to speak. And when there's an overgrowth of these things, normally, these bacteria and yeast, they secrete compounds that are just of origin of those microbes. You don't normally make them in your body. And they are secreted in the gut, they get absorbed into your body, and then you pee them out. Well, if the levels are really through the roof high, or even just very high, there's an overgrowth of those bacteria who are making those compounds. And so it's really a good marker for bacterial overgrowth in the gut. And it's another way to look at it. And I love to use the NutrEval in addition to a stool test and lay them side by side and just see if they make sense together. And I would say about 95% of the time they two of the things are aligned. Occasionally I get where one's positive and one's not, and that's an idea to think about for another day, which I've thought about. But for 95% of the time, the two things are very aligned in my experience. And so I'm very confident when I look at this dysbiosis panel that if the markers are very high, that I've got a gut issue. And if I haven't done a stool test, sometimes I'll use this as a screening to decide if the person needs a stool test, because maybe they don't have any gut symptoms. And so if it comes back positive, then the next thing they get is a stool test. Just a brief comment about the importance of gut flora for the immune system. A healthy gut, I can't emphasize more about a healthy gut is a healthy immune system, period. And the more research, the research on the microbiome now is, it's hard to keep up with the articles that are being published every day. And we know that, and I have a whole section on, the beginning of my book, I talk about all the reasons how especially in the section on healing the gut, about how the flora is critical for really the balance of your immune system. It helps the dendritic cells in your gut develop properly. It speaks to your developing immune cell. 70% of your immune system's in your gut. All those clusters of lymphoid tissue. There's naive T cells that are just waiting to be stimulated to grow and develop, and your beneficial flora speaks to that. Interacts with the dendritic cells, which then trigger the lymphoid tissue. So it's really, really, really important. And so. So therefore, screening for gut, so the dysbiosis panel in the NutrEval, to me, is like a critical way that helps me know if the money's in the gut, where's the problem here? Is it toxins? Is it the gut? And it's one of the ways you can decide. And we can talk about treatment later. I have all sorts of treatment protocols for gut dysbiosis. Okay. The next thing that's really important is an oxidative stress panel. And for those, just to sort of speak to what is oxidative stress, oxidative stress is really, I think it's a way to think of sort of the end result of not enough antioxidants to keep up with the generation of free radicals. So there's this whole, your immune cells as well as your whole body is always undergoing stress and then recovery. Stress, recovery, stress, recovery, right? So you have a demand on your antioxidants from a toxin or from going out drinking one night or just from your actual, everyday process of biochemistry. You need antioxidants to quench the free radicals in your mitochondria every day. And you might, and if you're let's say something good, like you're an athlete, right, and you're in training, you're going to be generating a lot of free radicals in your mitochondria. And so that puts stress on the system, and then you need to help it recover with antioxidants. The same thing with the immune cells. Immune cells are really sensitive to oxidative stress because they generate free radicals as part of the way that they kill the bad guy, the way that they deal with a microbe that they bump up against. They basically shoot it with free radicals. They make all these toxic compounds. It generates a lot of free radicals within the immune cell, and if the immune cell doesn't have the ability to recover, it won't function anymore. It won't work. And so your immune cells need a constant source of antioxidants to recover and be ready to fight again. It's like the soldier goes down. It's like resupplying the soldier with bullets, I guess is a good analogy. And so, therefore, you need to really make sure that if you're looking at the immune system and you want their immune system to be really healthy and robust and working properly, you really want to make sure that they have sufficient antioxidants, and that the way you know if they do is by measuring their oxidative stress. The other thing I will throw out is I've had some patients where the only thing I could find why their oxidative stress markers were so high and low, it's a combination, but why they had a lot of oxidative stress was because they had terrible dysbiosis. So dysbiosis can actually cause a lot of oxidative stress itself, just from the microbe overgrowth in the gut. But toxins, infections, and emotional stress, that's another thing. People, sometimes all I could find is something like a traumatic experience or 6 months of severe ongoing trauma, and the NutrEval changes, and their oxidative stress markers are through the roof just from that. I mean, I do believe that stress comes in and alters the gut, and that then, in turn, has the role perhaps in contributing to the oxidative stress, but these are all things that trigger that. So really, really, really important to check the oxidative stress of your patients. And the panel in the NutrEval there's an oxidative stress panel on the last page, which I'll show you. And this is where you look at glutathione, lipid peroxides, and 8-OHDG. And if you have low glutathione, high lipid peroxides, or high 8-OHDG, you just have a sense your patient's sort of losing the battle. And you want to support them with antioxidants while at the same time, in classic functional medicine approach, is find those triggers and get rid of them so that they don't have ongoing oxidative stress that's continuing to stress the system. Heavy metals is, the heavy metals test is the red blood cell test. And I want to move through this quickly so I can get to a case so we can get to questions. Red blood cells live an average 3 or 4 months, so a red blood cell metals test is perfect for looking at what's your current exposure. Do you have, in the past 3 or 4 months, given your current habits, how much mercury are you getting? And this is great for people who say, I'm fine, I don't eat a lot of fish, I don't think I have a lot of mercury. But you come back and all of a sudden the red blood cell mercury is really high. You can show your patient and say, whatever you're doing, even though you don't think you're doing anything, the current way you're eating fish, because in my experience, this mercury in over this is not from fillings. In my experience, consistently, this is from fish. And the only person that I have found once, a patient who didn't eat fish, that had high red blood cell mercury, and I have that on this slide, she was taking fish oil. She stopped the fish oil, and 3 months later, her mercury was gone. And so we did it as our own experiment. So people they think their fish oil is okay, but you can actually get ongoing mercury exposure from fish oil. Now, there's tons of studies on mercury and autoimmune disease. Not as many on lead, and not as many on arsenic, but there's a few on arsenic. But what I want to leave you with is this idea of it's a total toxic load. It's not, so if somebody has all those other metals, it makes them, it's sort of the cup floweth over more easily. So it just increases their whole toxic load, and it makes the body even more unable to manage the mercury. And then the mercury stays in the body and is associated with autoimmunity. And so certainly for sure, Hashimoto's, there's some really good studies on that. And so mercury is a big issue. So this is a great way. I do urine provoked overnight provoked urine testing with DMSA also. And after I do this test, I think of this almost as my screening. If somebody's high, I will go then and do the next test to look for total body burden. But it's really helpful to know when you, especially if you only do the urine test, you want to know, is this current or old exposure? And the 3 or 4 month red blood cell test helps you understand if this is old or current exposure. And then there's a detox panel. I'm actually going to just skip this. This is fine. I'll show you this in the patient case study. So, but there's another detox panel, a little panel in the organic acids. And when you look at all this together, it helps you know whether or not the toxins are where the money is, and that's the way to look at it from a high altitude view. Going to a lower altitude is really the individual nutritional deficiencies, and that's where I find the summary tables that are given to you from the NutrEval really helpful to just get a sense of, how bad it is, how nutritionally deficient are they really, and if somebody has tons of nutritional deficiencies despite a good diet, you really have to think of gut. And so that's, digging deeper and looking at the specific nutrients, that's sort of the next level. And for the immune system specifically, amino acids and minerals like zinc are really important for immune function. So you really want to know all of this. Okay, so just a general, this is what I was talking about on the front page of the NutrEval, and actually this is the front page of my patient I'm going to show you, I'm going to talk about next. This is the home page of her NutrEval, and when you look at this, and so she's a 60-year-old woman with rheumatoid arthritis. Actually, my first patient is younger, she was in her early 50s. A rheumatoid arthritis patient who was not on any meds, and but just was living with her pain, and I'll tell you more about it in a minute, but this is her NutrEval, and when I looked at this, I thought, geez, her Bs are like terrible, and her Bs are terrible, and most of her antioxidants are either borderline or high need, and so right there I know that I'm wondering, do I have a malabsorption problem, because that's a lot of Bs, and she's basically a healthy eater, eating really healthy food, and so when somebody on a really good diet who comes up like this, I really worry about the gut. And when you get your NutrEval, this panel is really, if you want to make custom amino acids, this is really a prescription. If you don't have a lot of experience in dosing of how much a person would need, this is your guideline to help you know how much you might want to give someone of each thing. And so you can see, like, the B vitamins, those are all red, and those recommended doses are sort of the Genova's suggestions for you. I tend to put together my own sort of program and not use this as much, but some people, you can send this to a company, a compounding place that makes custom vitamins, and they'll actually make you, if somebody doesn't want to take a lot of pills, they can make you a custom multivitamin with these numbers. And I do find that's really helpful with, like, teenagers or elderly people who don't want to take a lot of pills. And custom amino acids, I actually have done that a lot, and I do. So I take this and I send it off to do that. And then these summary pages are just so great for you. I don't go through this with my patients. I say, you can go home and read about, lipoic acid. You can see the X is in the red box. This is your lipoic acid need, high need, and you could read how the body uses it, what it's good for, what food to get, and people are like, oh, that's so great. So you can send people home and they can read about what foods to eat to get more of these nutrients. So I really like that. And so that's really just the first part of the test of what you're going to show your patients. So now I'm going to move on to my patient. Let's see, where am I in time? Okay, so we'll probably just get through the first, but you'll have a second case study when you get your slide deck, and you'll see my other case. But this is a really interesting woman who came in. She had RA. And she came in and said, I have RA. My first episode where I had, my first joint pain started when I was 35. I had this episode. I don't know why. I was given Plaquenil, and then I went into remission, and I went off meds, and that was 14 years before her second flare. And so for 14 years, she actually did not have a flare. She had no more joint pain. She was not on any meds. Thought all was great. Now, in her own sort of work, she decided to become, sort of healthier, right? And so she started cleaning up her diet, and she was reading all about the importance of getting silver fillings out of her mouth and, the amalgams. And at 49, she decided, I'm going to go and get all my silver fillings out. And she went to the dentist, and she started all this work on her mouth. And within a few months after she started all this dental work, she developed joint pain. And this was her second flare, which was 5 years before she came to see me. And so for the previous 5 years before coming into my office, she was sort of grappling with this on her own. She was trying to eat healthy. She'd been going to the periodontist. She actually also had terrible periodontal disease and was seeing the periodontist like every 3 to 6 months for treatments. So she knew about that. And so she was trying to help herself. She did not go back on meds. And a few months before she came in to see me, she said, I've been grappling with this for the past 5 years. My joint pain started after my dental work. I'm reading your book, and I just started the elimination diet, but now I need help getting through the rest of it because it's just too much for me to figure out on my own. And I actually see that a lot. I have an online program that people can do to get online support and like email support. They could submit questions and blogs and stuff to help them go through the book. But some people just really need, at the end of the day, someone to help them, and they go find a functional medicine person, me or someone else. Anyway. So when she came in to see me, her pain was 7 out of 10. Left wrist, both ankles, neck, stiff hands. And fatigue was her other big thing. She needed to nap in the afternoon. Her energy was a 3 out of 10. Now she's already on a really good clean diet. She's on the elimination diet. She's eating clean. She was already eating pretty healthy in terms of bringing in fruits and vegetables. But this was the first time she did an elimination diet. But the elimination diet didn't really help her. Did her gut, she had no gut symptoms, nothing. Good bowel movements. 10 years she wasn't taking antibiotics. She was really trying to keep, do the right thing. Early antibiotics as a child. And she's an optimist. So emotionally, stress 3 out of 10. She just takes it all, go with the flow. So she was like, I'm not going on meds. I try to manage my stress. I'm trying to eat healthy, but I want to figure out why I still have pain. And that was all well and good. Did her conventional testing. CRP was really high. She had positive deamidated gliadin antibodies. So gluten was, for her, a really important piece to her puzzle. Negative ANA, but her rheumatoid factor and her CCP were really high. So she clearly had very active rheumatoid arthritis. And if she went to a rheumatologist, they would have said, putting you on meds. You need meds. And she knew that, but she didn't want that. So she was sort of just stubborn and not willing to do that, and there we were. Vitamin D is 30, her iron's good. And so I'm thinking to myself, geez, her iron's good, she has no gut symptoms, and her story is after getting fillings out, this all started, she's a toxicity person. I think but she could also have celiac, or gut damage from the gluten, and so that could be a problem too for her, but her iron's good. So that was a very important thing to think about, right? Her DHEA was pretty okay. So I'm thinking, okay, her stress, she's managing her stress pretty okay, not so bad. Her white count 6.9. Okay. I don't think she's got a big chronic viral load. That's not it. So I'm thinking in my mind all the possible triggers. Not a big viral trigger. Maybe her adrenal stress system is okay. Maybe her gut's okay. And maybe this is, other than, we can't forget about the gluten, but, maybe this is toxicity. So I did send her home with that urine heavy metals test. And I gave her an adrenal test and I gave her a stool test. And because everything seemed good, I said, you know what, I'm going to start you on a detox program from the first visit. Send her home on the gut. Now, a lot of times I save the NutrEval for the second visit in somebody like this because it's too much for people to do all at once, and at the first follow-up, it's so much to go over. So usually the NutrEval for me, depending, is the second visit to the third. At the second visit, I do that test. So for her, we did these tests, and she came in, and here's her stool test, and she had really high EPX. Her eosinophils were high, not in her blood work, but in her stool, which made me think, okay, maybe it's either food, and maybe that could be from the gluten as well. And she had high beta, I'm hurrying because I know we're running out of time, high beta-glucuronidase. When someone has high beta-glucuronidase, it's always a concern to me that there's some anaerobic microbes that are overgrowing that are not good microbes. It's really an enzyme produced by harmful microbes. So there's some sign of microbe issue there. Her bile acid ratio is okay for the most part, maybe a teeny bit off. Not that impressive. And if you look at, her microbiology, which I actually can't. Let me just move this over. Sorry, I guess I wonder if you all were seeing that the whole time. It's really not impressive, other than she's not really growing good stuff. And so her stool test wasn't, terribly impressive, but it was a little off, right? So that beta-glucuronidase, I thought, okay, she has RA. RA is really associated with, okay, come on. Right, maybe I'll click back here. Okay. RA is really, sorry, I was focusing on getting the slide moving. RA is really associated with leaky gut. I mean, it's a known thing. She has to have leaky gut or something in her gut if she's got RA. And so I did decide to treat her for a short period of time with herbs. Her adrenals, I'm going to skip this. Her adrenals, it's a little imbalanced, but, that's not our main thing. I want to get to the NutrEval. So she came back, and so at her second visit, she comes back, and her metals were really high, very high lead and mercury. I had her send that off before she started the detox program that I gave her. And I thought, okay, I saw that stool test, not so bad. Metals are really high. However, she did the detox program, no change in her joints, nothing. She came back and said, okay, well, that was fun. I enjoyed doing the detox program, but I don't feel any different. And I thought, okay, well, gave her counseling on the fish, and I said, well, let's do a little gut cleanse. You don't need my big guns 2-month program because I don't see that. It's not that impressive so far. And instead, I'll give you some mild, or we'll do 2 weeks of some herbs and go do a NutrEval, and then come back and see me, and I want to see what's going on. And I left her on the detox program. I thought, okay, well, also maybe 21 days isn't enough to really see the difference. Maybe your toxic load is really high. So 3 months on detox, a little bit of gut, do the NutrEval, and come back. And she came back at her third visit, and there was still no change. And now, mind you, she had done 3 months plus, really almost 4 months of detox support. And her lab work really hadn't changed. And I thought her deamidated gleans went down a little bit to 25. And so we had to figure out where her gluten exposure was coming from. And certainly we could think maybe that's still an issue. But numbers weren't changing. And I thought, okay, we got to figure out what's going on with the NutrEval. And what I wanted to know from the NutrEval, now we're going to get to the last piece, which is the NutrEval. What I wanted to know is it gut or toxins? What can I, where do I go from here, and how can I use the NutrEval to help me understand? And when you look at this, and I'm actually going to, here's her dysbiosis markers. I mean, I almost fell off my chair. This did not show up in the stool test. This was all the bacteria markers were terrible, as well as her yeast markers. And she has malabsorption markers. And so, and of course, the test sort of generates this interpretation, which is the need for probiotics and enzymes, and says, yes, they need all that stuff. And so that's the, so that really switched me up in thinking that and say, okay, well then what about the toxins? Where are we with that? And here's my overall view of her toxic situation. Her metals were okay, so she's not getting any metals anymore. So her current, in terms of what we saw on the urine test was probably old accumulated stuff, and right now she's not getting any current exposures for the past 3 or 4 months, so we're good. Her oxidative stress markers were not that bad. I mean, her glutathione is teeny low, her lipid peroxidase a little high, but as a panel overall, and then you look at the toxin and detoxification markers, and those are just a little off too. And the first two are really more of a referendum on exposure to styrene and MTBE as an exposure marker, and then glutathione's ability to recycle it. So all the things in the detox panel are more about, a little bit of glutathione, is glutathione working in the body? And And so it's a little off. So clearly she needed some glutathione support, but she's still got 7 out of 10 joint pain. The toxins, are really clearly not where the money is. So I still have this woman with joint pain, and clearly I thought, okay, I'm going to send her home on a gut program. And so toxins aren't the main issue, need to circle back and focus on the gut. So next I did is GI effect stool. So gave her a follow-up stool test. I said, do this other kind of stool test. Let's see what's going on. And she had a very overgrowth pattern. She didn't really have SIBO symptoms, and I'm not sure. And her SIBO test actually came up mildly positive, which isn't on these slides. And so, I thought, okay, we have a little bit of SIBO that we're dealing with here, and maybe that's part of the problem. But clearly she has some dysbiosis, just she's not growing good stuff. Although she is high of a lot, we're not going to go into interpreting this right now. I want to get to what happened next. But clearly, I needed to do something with her gut. She needed a little reboot of her gut. And so I sent her home with 2 months of a gut cleanse, increased support for leaky gut, stopped the detox supplements, gave her all what she needed from the NutrEval. I gave her all those Bs. I gave her B12 shots, NAC, lipoic acid. I switched her protein shake to Inflamex and said, we got to work on your gut now. Sent her home, and she came back at her 4th visit and still had no change in joint pain. Now, and I'm saying this because this is just such an interesting case, the answer was still in her microbiome. But it turned out that it was her oral microbiome that was the issue because, and of course I'm busy doing all this research now on arthritis, and there's so much research now on the oral microbiome and the importance for pathogenic bacteria in the mouth actually being seeding the gut, and then also triggering CCP and rheumatoid arthritis, CCP antibodies. And so I sent her home with this whole water pick program for cleaning up her mouth, and 3 weeks later she called me and said, oh my God, my joints, within 3 weeks of doing the water pick with some, I put biocidin drops in the water pick for her, she, once a day, her joint pain was 3 out of 10. And so I do think that the mouth was seeding the gut, but I want to leave you all with the importance of this sort of factoid and teachable moment of don't forget about your oral microbiome, because the oral issue, and so my understanding of her case circled back to the issue was she went to the dentist, got all of her mercury fillings out, and she completely seeded her whole body with her periodontal disease that she had. And all that work ended up really flooding her body with all those microbes. And so I think that's what happened that triggered her flare. But you still have to get to the gut, but I think it definitely affected her gut as well. So I needed to clean up her gut, but the gut also starts in the mouth. And so that's the last piece that I want to leave you with. And unfortunately, we're not going to do case study number 2 today, but it's in there, and you'll get to look at those slides. And so I know I went over, I'm sorry, but I think I got in a lot of good stuff. I hope everybody enjoyed the presentations, and I'm happy to answer questions.
All right, great. Thank you so much, Dr. Blum. That was a great presentation. And there were some questions people were asking about if the presentation would be available. And so, yes, it will be available on our website next week in PDF format. So you'll get a chance to look at some of those case study number 2 slides when we post it up on our website. So we did receive quite a few clinical questions, and I'll start with one here. They were just asking about how might immunosuppressants influence test results, because you're presenting a case of a person with an autoimmune disease, and a lot of the time patients are on those types of medications, Humira or methotrexate or something. So have you seen that those in any way influence the testing?
No, and actually my next patient, which I'll just answer you by saying she's another RA patient who was on all those meds, okay? And so she came in on all those meds, and her, no, it won't change anything in the NutrEval, but the problem is the meds affect the gut, so you might see more issues with malabsorption, but the meds will affect potentially your white count. So conventional labs it can affect, right? Because it'll help bring down the CRP sometimes. Usually the goal is to bring down the CRP with the meds, and the and it'll change, and it can help, and it can actually cause a low white count, and that's not viral, right? So, but in terms of interpreting the NutrEval, I really can't see where being on medication would change any of the results of that. No.
Mm-hmm. Okay, great, thank you. And then we had another...
Wait, I take that back, though. Wait, I just want to clarify one thing. Methotrexate lowers folate. Mm-hmm. And so, methylation. You have to really, and so in a way, all your patients on methotrexate are going to come to you and they're going to say, I'm taking, whatever the prescription folic acid is. I'm taking folic acid, I'm taking methotrexate and folic acid. And the NutrEval then is really helpful, actually, to see whether they really have sufficient. Is that stress system, are you keeping up with the folate needs in that patient? So I think it is really important to know that. Yeah, go ahead.
Okay, great. Yeah, thank you. Well, and that's a great segue into the next question. So there was a person asking about just simply measuring folate levels versus the NutrEval recommendation for folic acid and what that difference might look like.
Okay, so that's basically just an explanation for how the test works when you measure do organic acids testing. The blood, when you measure in the blood, when you do a blood test and you're measuring any of the B vitamins, you really, in a way, it's helpful because you're really just measuring, are they getting it in through their diet and are they absorbing it in their gut, right? That's really all that test tells you. It tells you about current sufficiency in their diet and actually, a gut absorption. What it doesn't tell you is whether in all the different cells of the body where folate's required, down to the level of, the nucleus of the cell and DNA protection and all the methylation processes in the liver and all the methylation processes in all the cells, do you have enough folate to make all your biochemistry work? And the blood is just a transient sort of place where it comes in through your mouth, it comes in through the environment, you eat it, it goes into your blood, and then it gets distributed into the body. And so the blood level doesn't necessarily represent whether or not you have enough inside your cells to make everything work. And so the NutrEval test, which is an organic acid test, and by the way, if you can't draw blood, in my patients who live far away, sometimes I'll just do the NutrEval when they're visiting me, and then I give them an ONE kit, a urine 1 ONE, and it's basically a NutrEval. It's like a NutrEval, but it's urine amino acids, and you don't get the blood. You only get, in terms of the oxidative stress, you don't get glutathione, but you'll get the 8-OHDG and the lipid peroxides, which is fine as a place to start. But anyway, you can do an all urine test. The organic acids test looks at how well your biochemistry is working, and it looks at intermediaries of certain pathways. So, for example, in folate, it's looking at something called FIGLU levels, FIGLU, which is forminoimmunoglutamic acid or something like that. I probably got that wrong, but we call it FIGLU, and it looks at, I'll tell you, it's Formiminoglutamic. Thank you. Glutamic acid. Okay, thanks. And so FIGLU needs folate to be metabolized. And so if you don't have enough, folate is the main substrate for that enzyme that processes FIGLU. So if FIGLU is high, the only reason that it's high is because there's not enough folate to activate the enzyme to help metabolize it. So that's how the NutrEval works. So it measures FIGLU. So in this patient, her FIGLU was through the roof. The one I presented to you, she had really high FIGLU, and so that means that she just doesn't have enough. So her blood levels of folate might have been fine, but if FIGLU is high, she doesn't have enough for her biochemistry to work. The same thing about like MMA, which is methylmalonic acid. That's sort of the pathway test for B12. And when B12 is when MMA is high and hers was high, there's not enough B12 to catalyze the reaction to metabolizing MMA. So MMA builds up. It's sort of like when there's a river and you have a dam, and then the reservoir builds up behind the dam. Not having that vitamin cofactor causes a dam to form, and so it builds up behind the dam, and then those levels go up. So when you see these high levels in the organic acids test, it means there's a dam somewhere, and we know those dams are vitamin related. So does that explain it pretty well, you think?
Yeah, that's a great explanation, actually. Thank you.
Okay.
All right. Well, in the interest of time, we are going to have to end our Q&A period there. For additional educational materials, I'd like to point everybody to our website, www.gdx.net. On this site, you'll find sample reports, kit instructions, and other information for all of our profiles. And after taking advantage of the materials on our website, please feel free to contact client services with your questions. You'll see a number on the slide for US and UK customer service. Additionally, please call client services if you need assistance in setting up a MyGDX account. We also offer complimentary appointments with all of our medical education specialists to answer questions related to our testing, so including choosing the right test and reviewing patient test results. And we'd like to encourage you to look for upcoming webinars on our website. Next month, we have Dr. Pamela Smith speaking on case studies in the management of the menopausal patient. Finally, we have an upcoming Learn GDX seminar series, also with Dr. Pamela Smith as the keynote speaker. This educational workshop will be held in Fort Lauderdale, Florida on June 11th, and will focus on the comprehensive clinical management of the peri and menopausal patient. Each attendee is going to receive one Menopause Plus profile, which is included in the registration fee, and you can sign up for this workshop on our website. Thanks again, Dr. Blum. This was a great
Oh, you're welcome.
And yeah, and thank you all out there for joining us today.